Dear colleagues in the medical research, biology research, dear friends, partners, collaborators worldwide. In the post-COVID times, we get new challenges, opportunities, and responsibility. I started more than 100 years ago with the detection of the infectious parasites, the bacteria, later on the viruses, and the corresponding and developed diseases. We faced in the recent 18 months an unpredicted, unexpected new infection and pandemic. We from the biomedical research, we have to respond this now in the post-COVID times to get prepared for the new infection waves. 3D Histech, with you, with the funds and grants that are appearing in the world, we have now a new opportunity in the technical field as well in the research. After the digital microscope, after the optical microscope, now we have from 3D Histech a set of histological, cellular and molecular biological tools for the discovery of the reasons and make explanations for this infection. In this research symposium, in the oncoming hours, we will try to report to you how we and what we have developed for this research, a new area, and our collaborators from UK, United States, and from Switzerland will help us how we can get the earliest use and the best practices with these new technologies. Time will change, we will get new efforts, and we will get new support with this work and developments from 3D Histech. I hope you will find these following hours are useful for you. Thank you very much.
Good morning, good afternoon, and for some people, good evening. Thank you for spending some time with us today. On behalf of the company, it's my pleasure to welcome you to our second virtual symposium, Digital Solutions for Research Microscopy. On my screen, my name is Nicolette Csányi, your moderator today. I would like to introduce the agenda that you can find below as well. You will have the opportunity to have 9 presentations, 6 speakers from 3D Histech, and we gladly present 3 guest speakers from 3 different environments of the world who will speak about their own field. Before starting the symposium, just some housekeeping rules. Questions and comments are welcome. If you have any of them about the presentations, feel free to type it in the chat box. I will bring them up during the presentations and the speaker will reply to them. If by any chance you miss on some important points, do not worry, as a recorded version of this webinar will be available on our YouTube channel. Please stay tuned for further programs. So, the first speaker of today is Dr. Béla Molnár, the founder of 3D Histech. 3D Histech is one of the pioneers in digital pathology, developing and manufacturing digital slide scanners, software applications for the digital slides and other products, including tissue microarray machinery, supporting not only routine pathology, but also medical and pharmaceutical research, as well as medical education. Dr. Béla Molnár will speak about the digital microscopy and summarize the further topics, emphasizing the vision of the company.
Dear visitors and participants of the 3D Histech Symposia 2021 May, digital microscopy in digital slides, digital solutions for research microscopy. 3D Histech is your long-time reliable partner in digital slide scanning in the research in the last 20 years. At 3D Histech, we developed several types of slide scanners for Brightfield, Fluorescence, FISH, multi-fluorescence slide scanning. And today we would like to introduce to you the newly developed technical features and developments for molecular visualization, molecular imaging, slide archiving, digital slide archiving, digital slide sharing, and image analysis. Because the year 2020, in the COVID infection, in the COVID pandemic, and 2022 brings to us new challenges. Not only the specimen handling, not only the specimen visualization, but also the type and the methods how we do this work today for our image analysis, for our new image experiments on the slides, sections, cells, and even more towards the molecular evaluations of the altered cellular and histological areas and cell types are now a new, brings us new opportunities. The MIDI confocal system, which is 3D Histech for 2022, further developed, further established with the recent opportunities in the image recognition, image recording, and the fluorescence excitations give us new opportunities. Multiplex labeling, multi-type labeling, like DNA, RNA, protein, and in situ hybridizations and in situ connections, distance measurements, and functional measurements. At 3D Histech, we never stop. We respond to the new technological opportunities, your requirements, that you inspire us either in the hardware development, either in the software development, to bring to you new solutions. Despite of the arising of digital pathology, the diagnostics applications of digital slide scanning in the routine diagnostics, we believe, and we continued the research and development in the, for the research applications, like whole slide imaging, whole slide image analysis, like data visualization, three-dimensional and virtual but flexible self-developed image analysis tools. Not speaking about the tissue microarrays. So in addition to the digital slide scanners, my colleagues will show to you, report to you about the new slide scanning features, which gives to you entire freedom. Any type of specimen, any type of labeling, any type of one focal plane, several focal planes, three-dimensional imaging, we can now cover in different type of magnifications, different dimensions of magnifications, objectives, excitations, detections, fluorescence, with allowing to you such a variety of slide scanning, slide storing, and evaluations that I don't want to discuss in detail. But in the following presentations from the developers, product managers, application specialists, you can get and you can find that you need in your today's research work and the future projects. ERIC's research application and research slide scanning is entirely new, entirely further developed, not only in the scanning hardware, but also in the archiving, in the storage, in the sharing, and therefore we will have a special presentation from Dr. Ákos Ágyi about the slide center, or recently developed and closed slide storage, slide sharing, slide server tool and product. Just to demonstrate to you the difference that you can achieve by fluorescence, confocal imaging, look on the chromatin, on the different dyes, look on the cytoplasmic staining, and the sharp and very different color spectra, which is also very good in the standard fluorescence, but in the today's confocal, unprecedented and unexpected, a new opportunity. Just the demonstration of a fluorescence and the confocal kidney glomeruli image. And as you can see, even the last smallest chromatin details can be detected, evaluated, measured, and reconstructed in 3D. Today, the multiplex immunohistochemical image, either but for proteins or common proteins and RNA and DNA, with these present developments, gives unprecedented tools into your hands to detect the smaller alterations and changes. 3D Histech is a three-dimensional imaging, visualization, and evaluation company. Therefore, the new tools for three-dimensional visualization, not only the scanning, but also for measurements for you today, will be demonstrated by Huba Hajdú, Mr. Huba Hajdú, product manager, about the new slide viewer, which is a two-dimensional visualization tool. But in addition, the newly developed three-dimensional viewer for Brightfield serial sections, confocal serial sections for multiplex labeling. The digital microscope is not only the multiplication of the analog microscopy in the IT and the digital environment. It opens for us new opportunities. And you will have a special presentation from Géza, from Huba Hajdú about this. What type of further additional features are available in the new digital microscopes, in the plugins, in the open interface towards image analysis by Róbert, Paulik, and as well by image enhancements. The whole slide image analysis, the multifocal image analysis, the serial section image analysis for the whole slides, for the variety of cells, first needs determination and localization of the area of interest, the region of interest. Therefore, we just recently developed and finished artificial intelligence-based segmentation tool for cells, tissue compartments, which today can be linked to several multi-step traditional image analysis measurements like the histoquant tool, nuclear membrane measurements, immunohistochemical measurements, densitometric measurements, and SISH and FISH. The image analysis driven by and performed by artificial intelligence today or everyday's tool. On whole slide, on project-based analysis, we have now opened new opportunities. And this redesigned, redeveloped artificial intelligence in your tool, in your hands, in your tool set, allows to you and supports your work done interactively by your team, by yourself. The co-localization of the multiplex labeling is a requirement today, and this is what we build further in our databases, on our visualization and image analysis opportunities and hence. The visualization of the determined multi-parametric data set is a new opportunity as well, and you will listen about in a special presentation. 3D Histech works and developed in the last year's sample preparation in the tissue microarray, following your requirements, your inspirations, and the TMA master and the TMA grandmaster with the PCR, the new features, new opportunities for samples, collections, and further downstream molecular analysis will be one of our final presentations of today. I would like to welcome our guest speakers from the TMA application field, Professor Inti Zlobec from Bern, Switzerland, Dr. Corrado from the UK, and especially the new open image analysis opportunities by your recently developed script Quant tool will be reported by Professor Yukako Yagi, Memorial Sloan Kettering, New York. With your active presence, participation, with the presentation of my colleagues and our guest speakers, we will find, I hope, a new horizon arising for all of us, but in the post-COVID times, with the enhanced and further supported research and development grants with this recently development, new multifocal, multifluorescence, high resolution, imaging, storage, sharing, image analysis, and sample collections tools will give you not only a new horizon, but a successful year. Thank you very much. Welcome to you today.
Now we are going forward, and I would like to introduce to you the next speaker. Kornélia and Géza are going to talk about the Pannoramic scanner family dedicated to research applications. Kornélia graduated as a bioengineer and spent a few years in academic research where she got familiar with various fluorescent molecular biology methods. She has been supporting the research software development team with her experience as application scientist since January.
Good afternoon. I'm Géza Antalffy, Development Manager of 3D Histech Limited. Thank you for accepting our invitation to this symposium. It's a pleasure to introduce you our new software, the Pannoramic Scanner software for research. I would like to introduce Kornélia Kelemen. She is the application scientist of the 3D Histech Limited. Today, Kornélia will guide you through our product line designed for research purposes.
Thank you, Géza. So welcome everyone, my name is Kornélia and I am an application scientist in the research scanner software development team. In this section I'm going to talk about the digital panoramic slide scanner family 3D Histech offers for the various capacity research laboratories. In addition to the Brightfield and Fluorescent panoramic scanner, 3D Histech offers tissue microarrays and image analysis application to support the whole research workflow, but in this section we are going to discuss the scanner software and the scanners themselves. So in the past 25 years we have been collaborating with various research and routine laboratories, and we came to the conclusion that these fields demand different digitizing solutions. To this purpose, the Pannoramic scanner software team split to diagnostics and research scanner software development teams. As a routine diagnostic laboratories require high throughput and easy to use automated workflow, researchers prefer to have the freedom to find the most suitable scanning setup in order to find the answer to their diverse question, whether it is cancer research, pharmaceutical research, neuroscience, or any other molecular biology research. We, as the RX team, intend to support researchers in this matter, both when designing hardware configurations and when implementing the most cutting-edge features to the scanner software. And please let me introduce the research software development team. As Géza mentioned, he is the development manager of the team. Gergő and István are responsible for the development of software. Csaba and Kitty take part in the software testing tasks, while Géza and I hold field application trainings upon the installation of a new device or whenever the users ask for further education on the scanner software. So the 6 of us take part in the development of the research scanner software, which has the following user interface in microscope mode. We can choose the Brightfield and the Fluorescent mode from these modes very easily and switch with these buttons. We can switch from 20 or 40 magnification objectives by clicking these buttons. We can set the name of the slides and the folder paths of the output, scanning outputs. We can start the scanning with this green button. We can stop the scanning procedure. We can take previews for all the loaded slides in a magazine, and we have the opportunity to create profiles on the most frequently used settings of the slides. We have a preview window in which we can see the area of the sample colored in red. We can alter this area so we have many options to alter this area, and we have the opportunity to choose different focus mode. We recommend the application of the autofocus mode, but it is also possible to manually set the focus points. We have the opportunity to scan in single layer mode, or we can scan consecutive layers in Z-stack mode and in extended focus mode. We can alter the image quality, and we can choose from the compression formats and the image bit depths. The planner mode enables us to schedule the scanning process, so the scanning does not require any human intervention. In planner mode, we can just click on any slide positions, and in the profile, by clicking the plus button, we can assign predefine a profile in to each slide. In this window, we have the opportunity to alter the previous settings, and after we are done, we can just start the scanning procedures, and we can leave the scanner to scan automated. The P1000 scanner is a very unique scanner, as it has the greatest capacity of all 3D Histech scanners, and it has a dedicated software which is developed by another team. The P1000 is compatible with Sakura and Leica racks, and these racks can be inserted, and there is a special sensor that senses the slide positions in these racks. In the P1000, double width slides can be inserted, and single width slides can be inserted as well. It has a user-friendly user interface, and color coding helps the user to ease the setup. Settings can be applied to the whole rack, while we can assign profiles to slides individually. In the settings, we can set the output format, the output folder paths, and the scanner software can be connected to the hospital information system and the laboratory information system. In slides view, we can see a preview panel, and where we can see the area of the sample, and we have a window for the profile panel where we can set very similar. We can do similar settings to the RX software. We have the opportunity to set the resolution, the magnification, the multi-layer mode, to single layer, extended mode, or Z-stack, the focus distance, or the profile or the threshold. So these two scanner software are compatible with all the panoramic scanners, and this slide here is to summarize the scanner's 3D Histech offers, and we are going to discuss all the scanners in details in the upcoming slides. So 3D Histech offers one slide capacity scanner to low capacity laboratories. This is the Panoramic Desk RX, and there is a P1000 scanner which is ideal for great capacity laboratories. These two scanners are available in Brightfield mode, while there are scanners which can be ordered both in Brightfield and Fluorescent mode. These are the Panoramic MIDI RX, the Panoramic Scan RX, the Panoramic 300 RX, and we also have a confocal microscope in RX. The scanners can be ordered in a different configuration. All the scanners are equipped with size objectives. We have 20 and 40 magnification dry objective with a numeric aperture of 0.8 to 0.94. We have a water immersion objective with a numeric aperture of 1.2. This objective is available in the confocal scanner and in the P1000 RX. And we have a 10 magnification objective with a numeric aperture of 0.3. This objective is only available with the scanners equipped in fluorescent mode. Regarding the cameras, we have a 1.5 megapixel grasshopper camera, a 4.2 megapixel PCOH camera, which is available both in front side and backside illumination. And there is a 5.5 megapixel PCOH camera, which is available in the confocal scanner. And there is a 12 megapixel Adimac camera, which is available in the high throughput scanners, such as the P300 RX and the P1000 RX. As of the light sources, we offer LumenCore Spectra and LumenCore Sola light engines. These are 3D Histech Edition light sources. This lumen-core spectra is compatible with any fluorescent filters, while the lumen-core sola is only or can only be used with single band filters. And we have a PAX flash illumination option for the P300RX and the P1000RX. So let's start discussing the scanners in details. As I mentioned, the Panoramic Desk RX is a one-slide capacity scanner. It is only available in Brightfield mode, but both single and double width slides can be loaded in it. It is available with a grasshopper camera. And there is only one objective position available in this scanner, but it can be a 20 or a 40 magnification objective as well. The next scanner to discuss is the Panoramic MIDI RX. It has a slide capacity of 12, and the slides are positioned horizontally. It can be ordered both in fluorescent and Brightfield mode and in Brightfield mode only. In the Brightfield mode only version, the camera is the Grasshopper 3, and there are two available positions for the objective, and the 20 and 40 magnification objectives can be inserted. Meanwhile, in the fluorescent and Brightfield mode combined version, PCOH 4.2 camera can be added to the configuration. It can be ordered either with lumen-core spectra or lumen-core sola light sources. There are 10 filter positions available, and it can contain any of the 3 dry objectives that I mentioned before, the 10, the 20 or the 40 magnifications. And the 10 magnification objective is only available in fluorescent mode. So this image is taken of a hematoxylinosin stain in the mouse embryo section with 20 magnification and in single layer mode. And I brought another image taken on a mouse kidney section, which was stained with 3 fluorophores, and the image was taken with a magnification of 40 and in single layer mode. We have a Panoramic Scan RX scanner. It has a capacity of 150 slides. This means there are 6 tracks can be loaded in this scanner. The slides are positioned vertically. Very similar to the MIDI, it can be ordered in Brightfield mode only or in fluorescent and Brightfield mode combined. In Brightfield mode only, the Grasshopper camera is available, and the 20 and 40 magnification objective. While in the fluorescent and Brightfield mode, we recommend the PCOH 4.2 camera, lumen-core spectra or lumen-core solar light source, and the 20 and 40 magnification objective. We have a Panoramic 300RX. It has a greater slide capacity. It is capable of scanning 300 slides. This means there are 12 racks that can be loaded in it. Slides are positioned vertically, and it is available in Brightfield mode only and in fluorescent and Brightfield mode. In both cases, the Brightfield camera option is the Adimac quartz camera, which is a 12 megapixel camera, as I mentioned before, and the Brightfield light source is the PAX flash illumination. When fluorescent setup is available, the light source is lumen-core spectra and lumen-core sola. There are 10 filter positions available, and in both cases there are 2 positions for the objectives, and we recommend the 20 and 40 magnification in both cases. We have a confocal microscope. It has a slide capacity of 11. It is the confocal scanner is available in Fluorescent and Brightfield mode. The camera option is the 5.5 megapixel PCO edge camera. The fluorescent light source is the lumen-core spectra, and there are 4 filter positions available. And the confocal scanner, as I mentioned before, can contain a water immersion objective of a magnification of 40 and a dry 20 magnification, for example. So this image was taken on a human smear sample with 40 magnification. It was scanned in Brightfield mode, and it is shown in 1:1 real-time magnification. This image was taken on a mouse brain section with 40 magnification and in Z-stack mode. And in the next image is the 1:1 true magnification of the zoomed annotation of the very same slide. The magnification size bar shows us the 20 micrometer length. And there is one more scanner left which we need to discuss. This is the Pannoramic P1000 RX scanner. It has a slide capacity of 1000, and this is capable of scanning 100 slides in an hour automatically. It is available currently in Brightfield mode only, but both single and double width slides can be loaded in it. It can be ordered with Adimac quartz camera, and there are 3 objective positions available. A dry 20 magnification, dry 40 magnification, and the water immersion 40 magnification objective. The final magnification can be 10 to 82. And the light source is the PAX flash illumination. So this is all I meant to talk about today. Thank you very much for your kind attention, and if you have any question, feel free to approach us. Welcome everyone. Thank you very much for watching our presentation, and to the best of my knowledge we have not received any question in the YouTube chat box. So if you have any question, or just feel free to approach us via email or via LinkedIn or any kind of source. Thank you very much.
Thank you.
We are moving along to the next presentation. Our next speaker is Huba Hajdú. The product development manager will present a new software that will be available soon. He will speak about the 3D histology in Brightfield and Fluorescence from stereo sections. Huba, over to you.
Welcome to everyone. My name is Huba Hajdú. It is a great pleasure for me to announce that 3D Histech will be releasing a new software product soon. It is the 3D View, a 3D reconstruction software application. 3D View is a software that prepares 3-dimensional reconstruction of 2-dimensional serial sections. The software offers advanced visualization options and supports many file formats and so on. Let's see how is it working. 3D view's primary use is the reconstruction of tissue volumes in 3D from consecutive sections of an ex situ tissue block. Subsequently, it can be used to extract, measure, and analyze anatomical structures in 3D. It can be used with Z-stack slide and serial sections, both Brightfield and Fluorescent slides. 3D view is a viewing and measurement system providing functionality for slice view of arbitrary sections through a volumetric data set, volume view of a volumetric data set. There are features for color manipulation and changes of viewing parameters, semi-automatic reconstruction of digitized consecutive histological cuts to a three-dimensional volume. Measurement tools are available for assessing metric distances. With 3D view, it can be made snapshot and video export. With the stereo function, it can be made stereoscoping 3D rendering. And here is a file conversion option, which makes a conversion of supported formats. This list contains the following 5 formats, can be loaded in the main application and the reconstruction plugin. Let's see how to start. Making a reconstruction with the software is very easy. A reconstruction wizard guides you comfortably through the 5-step reconstruction process. Step 1 is browse the slides and open them. The order of the slides is important for serious sections and of course the quality too. Step 2 is the extracting sections. Then follows the automatic slide rotation processes. After the process is ready, the main application window is loaded with the 4 view. The reconstructed volumetric data set is represented in 3D view via this viewing system. The first window is the default view, corresponds to the original slice view. It shows the original microtome sections of the specimen. Next to it, Windows 2 represents the cutting plane in the Y direction, as if the sample was cut after a 90-degree rotation around its vertical axis. Windows 3 shows the cutting plane in X direction, as if the sample was cut after 90-degree rotation around its horizontal axis. In Windows 4 is displayed the reconstructed 3D volume. 3D view offers the opportunity to measure distances. To measure distances using any of slice views. This produces an annotation featuring a line and the measurement in numbers. The image including the annotation can be captured. The annotation will remain in place even when browsing through the slide stack. 3D view offers a number of visualization opportunities which help you analyzing the 3D volume. The editor has 3 tabs which allows you to manipulate color, transparency, and geometry of the volume. Now we will see how is it working. Not just serial sections can be opened with 3D view, but let's see. Here it is.
Yes, you're right. And we can do much more. But let me ask a question first. Why do you cut your FFPE block into dozens or hundreds of slides, scan it into 2D digital slides, and then reconstruct the original 3D patterns, which you have just sliced into many pieces? At 3D Histech, first we go for the original 3D specimen. Look at this mouse embryo. Tiny cute, isn't it? You do not know since you cannot look through paraffin. However, with X-ray detectors, you can. Indeed, you can perform X-ray CT acquisitions and first get the original 3D patterns of the specimen. Then, with the help of AI, you may be able to get even diagnostic value directly from it in many cases. In these cases, CT simply replaces 2D digital slice. In other cases, 3D CT reconstruction can be used as a kind of target guidance. Hey man, look at that suspicious area with those tiny patterns. You should get your 2D digital slice through that very area, and here it is. And then, in the end of the day, you put the CT slices and the 2D digital slice together in a fused image.
Thank you for your kind attention. I hope you like it. I haven't received any questions, so thank you for your kind attention. Goodbye.
Now this is the turn of Dr. Corrado D'Arrigo, consultant histopathologist of Poundbury Cancer Institute in Dorchester, UK. Digital pathology is used increasingly in histopathology for primary reporting, but some on-slide tests remain dependent on light microscope. They maximize the effectiveness of digital pathology, as many of these tests should be transferred to digital pathology platforms. They wanted to modernize their HER2 service and adopted digital pathology to improve quality and turnaround time. The use of digital pathology made it possible to redesign their service to include the full diagnostic workflow and the necessary tools for monitoring analytical performance, training in interpretation, demonstrating competence, and maintaining diagnostic alignment. Here he will present their experience of transforming the HER2 diagnostic service using exclusively digital pathology.
Oh, and thank you for inviting me to present at this meeting. My name is Corrado D'Arrigo. I'm a consultant histopathologist at Pambury Cancer Institute. This is where we are, near the south coast of England. These are my disclosures. Just as a brief introduction, I've been working in the NHS as an histopathologist for over 30 years, and in my previous role in the NHS, I was head of service and clinical director for histopathology. Back in 2015, we founded PCI to provide companion diagnostic for oncology and to advance histopathology. And our institution is primarily focusing on innovation and providing translation of discoveries into clinical practice. Notably, we have been the first laboratory in the UK that used digital pathology for primary reporting and with an ISO accreditation for this standard. And we've been the first lab, for instance, to deliver comprehensive panel oncology biomarkers with a 24 hours turnaround time. We strive to integrate conventional and molecular histopathology in the same report as part of the innovation and the evolution of our profession. I've also been involved quite for a long time with CATCAS, that is a community interest company, non-for-profit company, that is interested in the training and teaching of companion diagnostic, in providing proficiency testing, and in general ensuring that there is good quality in cancer diagnostics. Okay, so today this talk is about HER2. So let's have a look at what HER2 is. This is a little cartoon that shows a three-dimensional model of this receptor. It's a transmembrane receptor. It's part of the epidermal growth factor receptor family, of which epidermal growth factor receptor is the most famous, also called HER1. And there are others. There is HER3 and HER4. All of them work by having a ligand binding site that activates the molecule and enables dimerization. And there is an intracellular kinase domain that fires off intracellular signaling. Interestingly, HER2, which is the subject of our talk, doesn't seem to have a ligand. At least we do not know what is the ligand for HER2. Schematically, the tyrosine kinase signaling of the EGF receptors work mostly with this type of scheme. There is a soluble ligand, EGF, and it binds into the ligand binding pocket, and that enables dimerization with a similar receptor, and bringing close together the tyrosine kinase domains, enabling autophosphorylation and then the downstream signaling. Now, HER2 for a long time has been known to be a proto-oncogene. What does a proto-oncogene mean? It means it's a normal gene that in some circumstances can become an oncogene. And usually these circumstances are oncogenic events that are affecting the gene. And there are lots of different types of oncogenic events, like enumerated here. But by far the most common event is amplification in breast cancer. So here is a little pie chart of all breast cancers, and those that have HER2 amplification represents about 15% of all breast cancers. And the mechanism of action of HER2 amplification is not entirely known, but it is postulated that a lot of these HER2 receptors floating around in the membrane because of overexpression facilitate the coupling of the internal tyrosine kinase domain of EGF. So you require much lesser density of EGFR and EGF signaling in order to activate the downstream pathways. Of course, EGF and EGFR are key signaling molecules for epithelial cells, and breast cancer is by and large a very well differentiated epithelial cancer, and so the EGF signaling is important for breast cancer. And we know that HER2 amplified breast cancer identifies a subpopulation of breast cancer patients that have a particularly aggressive disease, and this is an example of very early PT1A breast cancer, node negative, no metastasis. But as you can see here, as opposed to non-HER2 amplified cancer, the disease-free survival is relatively bad compared to the rest. These are months in follow-up. And everybody's interested in HER2 because for the cancers that have HER2 as an oncogenic driver, the targeting of HER2 by a combination of strategies is quite successful in providing better outcomes for these patients. So in general, this is a list of the current treatment strategies available in breast cancer. In general, there are three classes of molecules that can be used. One is molecules that are conjugates of antibodies and a chemotherapy drug. So the antibody drives the drug to the target, and then the drug is internalized and then is cleaved and therefore is released to act intracellularly on the tumor cell target. The second class are molecules that are derived by from monoclonal antibodies, and they physically inhibit, interfere with the physiological action of HER2. And the third class are tyrosine kinase inhibitors that inhibit the tyrosine kinase domains of these EGFR receptor family members. So how do we assess HER2 status clinically? This has been established for a very long time, and the strategy is very simple. At the beginning, for upfront, we do immunohistochemistry using an appropriate antibody, and immunohistochemistry looks at overexpression of the protein, and the results are classified according to the staining intensity, the amount of staining that there is on the tissue section, as no staining, 0, or mild staining, 1+, moderate staining, 2+, and strong staining, 3+. And the outcome of this classification is that if there is 3+, the cancer is classified as HER2 positive. If there is 1+ or 0, the cancer are classified as HER2 negative, but in fact, we now have a new category for biomarker as HER2 low, for which there are some treatment options. And in the case of moderate staining, the case is classified as borderline or indeterminate, and we reflex it to a second orthogonal test that in most cases, in the greatest majority of cases, is in situ hybridization. And of course, as a result of in situ hybridization, the case can turn out to be negative, or therefore classified as HER2 low, can turn out to be positive for amplification and therefore HER2 positive, or may remain borderline because there are still some uncertainty associated to the number of copies per cell. Okay, so in situ hybridization traditionally has been done using fluorescence, and a long time ago was a single color fluorescence looking at HER2 genes, and the technique has been refined somewhat because we realized that we need to understand how many copies of chromosome 17 there are, which is the location of HER2, the HER2 gene, in regard to the number of copies of HER2, because we were risking classifying polysomia of chromosome 17 as HER2 amplification. And a fish, a dual-color fish, would look something like this, where there are two probes, one for chromosome 17 in green in this example and one for HER2 in red, and you just count the number of these signals and you make a ratio. A second technique is a chromogenic solution using dual probe, chromogenic in situ, hybridization, and here I listed some comments about it. The dual probe definitely gives very sharp signals and high spatial resolution, so you can count with confidence even clustered signals, as you can have a good idea on how many copies there are in there. Unfortunately, it needs a dark room and a fluorescent microscope, and pathologists have never really been fond of dark rooms and don't really know how to operate fluorescent microscopes. So traditionally, in many places, the assessment is not done by the pathologist, but it's done by the biomedical scientists. And alas, we don't have enough biomedical scientists for the workload, so there are enormous delays in providing FISH results. Because the assessment is in a dark room using a fluorescent microscope, it's quite difficult to correlate with the results of the immunohistochemistry. It's very difficult to swap slides. You need to change the illumination of the microscope. It's very cumbersome, and so this correlation is not very often done. Of course, if we wanted to do digital pathology on the whole slide, this is really not possible, not in a routine setting. The amount of tissue you need to scan is very, very large and at the resolution required, and is beyond the scope of routine clinical digital pathology. The other serious downside of FISH is that the preparation has a limited shelf life, although it has been extended in recent times by using substances that retard the bleaching of these probes. Nevertheless, you cannot really review a case that is several years old to understand whether the diagnosis was correct or not, or in view of new finding or new diseases for the patient. Conversely, DDISH probably suffers from a lower spatial resolution than FISH. However, the plus point is that we can use our microscopes that sits on our desk. We don't need to go in dark rooms. We don't need to learn how to excite and filter the light. And clearly, it would be very amenable to whole slide digital pathology. We know that the correlation with immunohistochemistry is very easy. You can swap slides and look at the immunohistochemistry and find the right areas. Another very important point is that because it's easy and because it uses the microscope that us pathologists use all the time for routine, it means that more pathologists are keen to do the interpretation themselves rather than subcontracting it to the clinical scientists. And that means that there is continuity in the diagnosis, which is by far preferable. Also, because the preparation is permanent, you can go back and review all cases if necessary. And here are some examples of the DDISH with a dual color. In red is the chromosome 17 probe, in black or silver is the HER2 gene. Okay, what does a clinical HER2 service look like? And I've drafted here a typical routine work that comes from a clinical service. So days of the week here at the top, and it's all cyclical, 1 week after the next. And the key area is this breast MDT. I mean, especially in Britain, nothing happens if you do not discuss your cases at MDT. You simply do not see the patient, full stop. So whatever you need doing, it needs to be done before the breast MDT. And if you skip the breast MDT, it means you can discuss it only a week after. So you lose a week of time. And there are a lot of cases, and if you keep postponing, you end up with a huge backlog. So breast MDT is a necessary stopwatch here. Typically it's towards the end of the week. I put it on Thursday because that's where my clinical practice is, but sometimes it's on Friday and sometimes it's on Monday. Typically there are outpatient clinics, which is where the core biopsies are taken, and typically there are about 3 separate clinics during the week, and one, for instance, here is on Friday, but Friday gives a lot of time because before the next Monday we can make a clinical diagnosis on H&E, and we can order HER2, and if by any chance HER2 is indeterminate, we can order DDISH and have it on Wednesday. So everything is ready for Thursday. And the Monday clinic, similarly, we kind of get it on time. It's a little bit more hairy and a little bit more hurried, but usually even if we have to order DDISH, can be done. The problem is on the Tuesday, then we don't really have a lot of time, and that means that if you're not very well organized, some cases will miss the breast MDT deadline. So, some considerations. We already have an excellent HER2 service for immunohistochemists using conventional microscopy, so why changing something that works well? True, but often whenever cases are complicated and have multiple requests sending forwards and backwards to laboratory, often the slides are lost in transit, and we often have cases where only we have half of the slides, and that becomes tricky because you should really continue to interpret cases having the whole of the material in front of you, so that's kind of a downside. Now, the other problem is that if by any chance the reporting pathology is not available on site at the time that the immunohistochemistry is out, the case will be delayed. And maybe digital pathology may help here, because digital pathology would ensure that even if the pathologist is off-site, could look at these slides and, if necessary, order the DDISH. FISH is definitely a bottleneck. Lack of BMSs means that sometimes you wait for 2 or 3 weeks before you get a FISH result. And if we adopted DDISH, that may improve turnaround time, because we have many more pathologists that could read DDISH than BMSs. Also, DDISH could possibly make an end-to-end digital pathology for HER2 possible. We can definitely scan the immunohistochemistry. We possibly can also scan the DDISH and interpret the DDISH using DP, and that will make a complete circle for HER2. Also, digital pathology would certainly facilitate the review of cases for MDTs. You don't have to go out and search for the slides. They're always cataloged there and always available. And also will be helpful when you want to present difficult cases to your clinical colleagues and discuss with them. Also, digital pathology would definitely facilitate comparison between internal controls among runs over the years to ensure that your analytical performance of the test remains. And also, digital pathology would enable better training in interpretation, because at present it's quite difficult with glass slides, and it's really difficult to try and teach FISH interpretation because of the constraints about storing and transporting FISH slides and also observing FISH slides on multi-heads. Okay, so is HER2 reliable? Is digital pathology reliable for interpreting immunohistochemistry? So, if you remember this slide that we saw before, a very strong, important factor is recognizing the staining intensity, mild staining intensity, moderate and strong staining intensity. Now, the intensity of membrane staining is something that is very difficult to define, and the lack of this definition means that we have very poor inter but also intra-observer reproducibility. So here comes one of my favorite parts of this talk. This is Joseph and the magnification rule. This is my friend Joseph Ruschow, who is a pathologist in Germany, in Kassel, Targos, and he has been involved from the very early days in HER2, and he was very instrumental in the TOGA trials, etc. And he perceived that this lack of standardization renders HER2 diagnosis very unreliable, and comparison of diagnosis among pathologists very difficult. So he said that we can use the optical property of the microscope to define line thickness, and that line thickness not staining intensity is the key for HER2 interpretation. The two things are very related. And to do that, he uses the lenses of the microscope to define that. So in order to understand that, we need to have a little detour. I'm very sorry, but maybe it's a little bit educational in some way. So we need to talk about airy disks and airy pattern. I think there is a spelling mistake here. This should be airy. And airy is this gentleman, George Bedell Airy, long passed away, but a great mind in the physics of the telescope. And this is a phenomenon that has been described, or was described almost a century, well, more than a century earlier, by John Frederick William, and then explained by George Airy. And that optical devices cannot generate a point image, and this is due to diffraction. And so the Airy disk is a series of concentric levels of energy that wave between positive and negative light energy, where obviously the stronger amount of energy is here in the center, and then there are ripples of negative and positive energy, and they look like this, and this is a three-dimensional organization of the whole phenomenon. And this is a property of the optical systems we use to look through the transmitted light of the microscope. And that the Airy disks are different at different magnification. And they follow a criterion that has been defined by William Strutt, 3rd Baronet of Raleigh, so it's called the Raleigh criterion, and he was a very famous physicist who won a Nobel Prize for Physics in 1904. Essentially, it says that if you put 2 points close to each other, because of the airy pattern and the airy disks, the human eye can distinguish 2 separate dots when there is at least a 20% decrease in the minimum between the points. But if it's closer than that, we perceive it as a single point. So that defined the optical resolution of a system. And this is the last gentleman I want to introduce to you, is Ernst Abbe, who is famous for his contribution with Zeiss to the evolution of microscope. And Ernst Abbe described the numerical aperture of an optical system back in 1882. He described that the resolution of the system, and we have this number, which is the numerical aperture, this little number here after the magnification, which describe how close together we can observe 2 points. And you can see actually that this numerical aperture is not just related to the magnification, but also to the quality of the optics. So here is another lens of the same magnification, but it has a lower numerical aperture. So the highest the numerical aperture, the finest the resolution of the system. And the interesting thing is that whatever system you use, a Plan 4 or Plan Apple, the numerical aperture increases with the increase of magnification, as you can see here. So there is a ratio as you change optics. Okay, so back to Joseph. So Joseph says that if you see a line at 4 times, if you see a definite line, that means strong staining intensity. It defined once and for all what is strong, 3+ if you want, staining intensity. If you need to engage with a ×10 in order to see this line well, it means it's a moderate staining intensity, 2+ in all money. And if instead you need to engage at ×20, that means it's a weak staining intensity, 1+ in all money. ×40, maybe if you really need to have ×40 to see it, probably it should not even be called positive. Now, there are a few disclaimers down here that says, obviously, different lenses have different resolving powers, etc., etc., and also, depending on the chromogen you use, and therefore the wavelength, it depends, the numerical aperture changes. But nevertheless, what this system says is that you can use your lenses of your microscope to reset your parameters for weak moderate and strong staining intensity. So the question about transferring a HER2 immunohistochemical interpretation for clinical diagnosis from light microscopy to digital pathology is, the first question is, can we actually use the magnification rule with digital pathology? Because if that doesn't work, then we struggle to clearly define something as important as line thickness that we all use to try and be concordant with each other. So we compare glass slides with digital pathology and the same cases, and read them with a microscope or with a digital pathology microscope, and 40 of each, and there is concordance. So yes, we can use the little click-on magnification systems of the digital microscope, and by and large we have the same understanding about line thickness that we have with optical microscope. That's encouraging. And here are some examples. This is a case looked at time 5, can't see very much here. Engage, put in times 10, still not much staining. Actually, I don't see any line staining. Maybe there is a little bit of slightly diffuse cytoplasmic staining. Put times 20, maybe there are 1 or 2 dots. I can see something here and here, maybe here, but nothing I can really confidently call a line. So this case is a case of negative HER2 expression. That's another case. Here I start to see something. Maybe there are some lines here, but I'm not entirely sure. I feel I really would like to engage the next power, and at the next power there may be some lines here and there, maybe some tiny little amount. Maybe these lines are beginning to be of 2+ staining intensity, but I also feel there is a little bit more in this tissue that I don't see. This is times 20. At times 20 I can clearly see a lot more staining. So this is now 1+ staining intensity, is a discontinuous membrane staining. I'm happy to classify this case as 1+. So there's another case, again time 5, some ill-defined brownness here and there, but nothing really to be very convinced. This is times 10. I can really see some lines now. They are discontinuous, but I can definitely see lines. So these are 2+ staining intensity lines, and here you see at times 20 much more clearly, because also the weaker lines come into focus, and this is a case that probably should be classified as 2+ and reflects 2-ish. And that's another case with the time 5. We can clearly see membrane staining, circumferential membrane staining everywhere. We don't really need to engage time 10 or times 20. We understand this is a positive case. So whenever we do immunohistochemistry, we now put on-slide controls. So this is the test samples, and these are the control cell lines. Control cell lines are fantastic because they continuously give you the same performance from slide to slide, so there is no difference in the depth of the block. So you're quite happy to rely on the staining intensity, and you learn to read them to reassure yourself that the analytical performance of the test is correct. And these are examples of the negative control cell line at times 5, times 10, and times 20. Maybe a little bit of a blush here in the apical membrane, but nothing else. This is the weak staining cell line, nothing at times 5, very, very little at times 10, and now we start to see the lines at times 20. So this is a good example of good control for 1+. This is the moderate staining cell line. Can't see anything here. Yes, I think there are some good lines here. I can see quite a lot. Of course, at time 20 I see more, but I already begin to see these cells that are staining circumferentially at times 10. And this is, of course, the strong staining cell line that is clearly visible at times 5. Okay, so what about ISH? So the principle of the DDISH, so that's the chromogenic dual apten test, is that you have a probe that hybridize to HER2 gene, which is labeled, and then there is an antibody hapten system, and then eventually a precipitation of a silver reagent. And then the second signal is a probe that hybridizes to the centromere of chromosome 17, and that is developed using an NP-labeled anti-DIG antibody, and therefore, and then develop a red signal. And this is an example of two examples of amplified and non-amplified cells. Here you see the chromosome 17 signals, and these are the single gene dot. This may be a doublet. Some of them are a little bit broader, not really entirely sure. This is a cluster, a small cluster, and you make a ratio. This is a non-amplified picture of a non-amplified case, and here is a case that shows much more clustering of the HER2 signals, still not very many red signals, so you can see that in many of these cells the ratio between HER2, number of HER2 genes and chromosome 17 are below 2, which is the threshold for amplification. So that's an example of amplified case. Okay, so I've recorded a few slides that using digital pathology, so to show you how easy is the interpretation of the D-dish in chromogenic. So that was an H&E, we were looking at it. This is the immunohistochemistry. It shows patchy signal. So this is strange. There are some cells that seem to be strongly expressing HER2, others not. Is this a case of mosaicism? Is this a case of poor pre-analytics? I don't know. So we reflex to fish, to the dish. These are the control cell lines which have amplified. This is an amplified control cell line. You can see the tremendous number of large clusters of the silver signal. This is a borderline case with a few excess of red, black signal over red, and these are cases instead where there is a good balance between number of HER2 genes and chromosome 17, and this is the fourth cell line, which is the negative cell line. These cell lines have both the protein levels and the gene level, which are matched and very nicely match the necessity of the test. So this is the test slide, and you can see how clearly we can identify the silver signals and the red signals. You should count 20 cells, but actually, to be honest with you, after you do this job for a while, you realize that you can see pattern. You can see this is an amplified pattern. You can count as much as you like. In the immunohistochemistry, we had some weak and some stronger staining cells, but here most of the cells seem to carry an amplified signal. Obviously, there are some cells with much more amplification than others, but I think in general this is a nice example of a positive case. Here is another case, is a cord biopsy. And you see here how easy it is to look at these cases using the digital microscope. Have you noticed that you don't need to focus with the digital microscope? I never really paid attention to that, but the pain of focusing is gone. So here is the HER2 immunohistochemistry. There is discontinuous and very occasionally continuous membrane staining with intermediate and sometimes with a strong staining intensity. It is an intermediate in the terminal retard. You need to reflex to fish or D-dish. So this is the D-dish. By the way, this is a nice clusters of lymphocytes. You can have a look at it and see how diploid cells look like, and single copies, of HER2 per cell. These are fibroblasts in the stroma, the same thing. Here are the cluster of tumor cells, and you can see how easily the signals can be separated and counted. So the performance of the digital microscope is very similar to the one of the optical microscope. And by the way, we have not scanned these slides doing any digital trickery. These are not stacked images and flattened. There is nothing like this. These are routinely scanned slides that we use for our diagnostic routine. There's nothing more to it. Okay, so what else digital pathology enable us to do? So, for instance, the fact that we can now have all these cases digitized helped us put together workshops for interpretation. And this is an example of a workshop we did probably about a month ago. Obviously now everything is virtual, but it works very well. And it's very difficult to provide a workshop for interpretation of ISH when you use fluorescence in fluorescence staining, and it's also difficult to provide workshop when you have glass slides, because you cannot really reproduce all these the same samples and stain it lots and lots of times. It's very expensive and very difficult. We also have been providing circulations for interpretation of biomarkers, and we have been able to do the same for the dish. So these are good aid to both for your own staff, but also for pathology community at large, to ensure that we are all aligned when we report and diagnose these biomarkers. So we are kind of approaching the end of this presentation. So what happened to our turnaround time? Do you remember that there is this anxiety of getting ready for the MDT and not missing that very last Tuesday clinic diagnostic core biopsy bunch and get them all ready and lined up for the MDT? Well, I think looking at what we've done, and we've now been using digital pathology for HER2 as a whole, end-to-end, for the last year, we've noticed an improvement, a small improvement, but still a significant improvement in our 24-hour turnaround time. Obviously, we are not managing to get every single one of these tests done within 24 hours, but we're getting closer. And our 48 turnaround time has improved enormously as well. And just here I copied a very kind message we received from one of our colleagues in a distant hospital for which we provide HER2 service, to say how much difference these rapid turnaround times have made for their patients. And I think this is ultimately what we all work for. So, in summary, today we have looked at the importance of HER2 in breast cancer, and have looked at how we determined HER2 status clinically. We compared glass slides with digital pathology for interpretation of immunohistochemistry HER2. We also looked at using DDISH in digital pathology and showed that it is very, very feasible to use digital pathology for the DDISH preparations. And also we looked at completing the circle, so using this wealth of digital material to compile training courses, diagnostic alignment with proficiency testing, making sure that your internal quality assessment assurance works well, and more. You know, we have also we've also started to provide digital atlases of patterns that recognize the patterns rather than counting, and that's very useful. What we have not had time for is discussing how digital pathology really is a connection to artificial intelligence, and artificial intelligence is going to be a safer and more consistent way of interpreting these staining patterns, so that we are safer and provide a better quality service. That is not possible without digitizing your preparations. And also we have not discussed the HER2 law. HER2 law is a new biomarker, and whether digital pathology is suitable for this new biomarker. But this will be probably the subject of another discussion. So for now, I leave you with this picture from the air of a nearby beach near here. It's called Chesil Beach. Is a very interesting phenomenon. It's a 29-kilometer long stretch of pebbles that was formed around 10,000 years ago after the last ice age, and forms a natural barrier between the channel, the English Channel, and this inner lagoon that you see on the left-hand side, within which there is a colony of swans, which are usually solitary birds, but in this particular environment they live together. There is a colony of more than 10,000 birds, which are incredibly an incredible sight to see. So this is all for me, and I'm very happy to take questions, and thank you very much for listening.
Thank you for the questions. I have a question here on the chat. The question is related to the use of digital pathology for fish slides. Would digitization of fish slides be a good solution for extending the shelf life of the fish preparation? Of course, it would be, because that would make it permanent, and fish, the permanency of fish preparation has been the Achilles heel of fish, and so absolutely at present the systems we have are unable to perform such digitization with the speed and the resolution that is required for interpretation, and I'm pretty sure that in future this will become easier and easier. But I think, as I showed you in this presentation, the chromogenic in situ hybridization is a very, very good substitute now to the fluorescence. Clearly there are other applications where fluorescence is preferable, and yes, that would be a really good thing if there was a digital microscope that could cope with the fluorescent images in a routine setting. That means volume. I didn't really make clear very much the numbers, but we digitize around 20-25 H2 slides a run, so this cannot be something that takes hours to digitize. It needs to be fast scans, taking maybe a minute or 2 minutes at a time. So I don't see any more questions, so I take this opportunity to say thank you very much for inviting me to present here. I think the field of digital pathology is clearly a field now in a very rapid evolution. I think that unfortunately there are still very few outfits that use digital pathology for primary reporting, and across the board, and we here in Panbury, we are really proud to be one of the places that pushes this frontier forward, and in our experience, digital pathology has helped us quite a lot to achieve better quality of service delivery. So so thank you very much, and I sign out from Dorset in the UK.
The next presenter will be Dr. Ákos Ágyi, Product Manager at 3D Histech. He will present our slide management products intended for the research market. In his presentation, Ákos will try to identify the main requirements expected from a slide management system from the researcher's point of view. For each requirement, a 3D Histech solution will be presented in detail during his presentation.
Hello and welcome for everybody. My name is Ákos Ágyi. I'm product manager at 3D Histech. Today I would like to show you our slide management solutions. Before showing you our slide management solutions and their features, I would like to start with a question. What do you need as a researcher from a slide management system? I tried to put together some requirements which could be natural for a researcher. For example, you can expect from a slide management system to store your digital slides and your protocol details or laboratory notes safely. It is also required to have a flexible folder structure. It could be really useful to have multiple viewer solutions in order to be able to see your digital slides in all cases, even on the go. Nowadays, remote teleconsultation sessions and slide sharing is also a must in a slide management system. It could be also useful to be able to make image analysis on this system and to have compatibility with other third-party slide formats. Let's see first the basics. The most important part of a slide management system is the storage of the digital slide. It could be natural that a researcher also wants to store, for example, some macroscopic images about the original state of the sample or about the experimental animals or plants. It is also useful to be able to add some notes to your slides or to add protocol details, to attach any document which supports your research process. Fortunately, in our Slide Center server application, you can do all this. Slide Center is able to store your digital slide images, and if you would like, you can add some notes to your digital slides, for example, the results of your microscopic investigation. It is also possible to upload some pictures in the system, and you can also add some notes to these pictures. If you would like to attach a document, such as a Word or PDF document, you can do that simply by clicking on this button. Since the slide management system stores all your valuable digital slides and research data, it is natural to expect that the system has advanced user management features. In Slide Center, we have a hierarchical user system. On the top of this, we have the administrator user with all the rights and privileges. This is the user who is responsible for the system. The administrator user can decide which user has access to which folder in the system. A moderator user can access only folders to which the administrator user give access to the moderator user. The moderator user can also give access to his or her own folders to other users, for example, for the normal or for the restricted user. A normal user can access folders to which the administrator or the moderator user granted access to him or to her. A normal user has full access to these folders, can open and even delete digital slides from there. A restricted user is similar to the normal user, but this user doesn't have a right to delete a digital slide. We also have a public share user. As the name suggests, this is not a proper registered user. This user can be used to share slides with outsiders, with persons who doesn't have a proper Slide Center account. I will speak in detail about this later in my presentation. In Slide Center, it is also possible to create user groups. This means that you can include, for example, all your research team members in a group. And by doing this, simply just by selecting the group, you can assign folders to all the people in your research group. But using research groups can be also useful, as we will see in this presentation, for slide sharing and for teleconsultation purposes. It is important from a slide management system to offer flexible folder structure. In our Slide Center, we have different folder types. On the top of the normal folder, we have specialized folders such as case and block folder. These are intended to support the anatomical pathology workflow. When there are cases, in the cases usually are tissue blocks. So normally in a case folder you can have block folders, and since the slides, the sections are usually made from tissue blocks in a block folder, just like in real life, you can have only digital slides. If you are not interested in the pathological research, you doesn't need to use these specialized folders. You can use just the normal folders, and as you can see here on this picture, even by using normal folders, you can create all kinds of folder structures with basically as many subfolders as you wish. After storing your digital slides in our slide management system, it is really important to have a proper solution to view them. In Slide Center, you can decide if you would like to open your digital slides in the browser or in the application. If you select browser, our instant viewer will open your digital slide. If you select application, our full-featured slide viewer application will open the digital slide for you from the server. Our instant viewer, as you can see on this screenshot, lives inside the browser. This means that you can use it on your PC, on your Mac, on a tablet, even on your Android phone. Instant Viewer is the perfect on-the-go solution to see digital slides basically anywhere and on any device which has a recent web browser. Our Slide Viewer solution is a full-featured viewer. This can be installed on the Windows operating system. And on the top of the basic viewer features, Slide Viewer can offer some advanced features and options. For example, you can run image analysis on your digital slides by using our Quant Center software. If you cannot find any automated solution or image analysis algorithm which is a good fit for your slide and for your research purposes, you can still use our marker counter to manually count some objects on your digital slides. By using the multi-view feature, you can visualize multiple digital slide images in the same window in the same time. If you are interested in TME technique, you can use our TME spot finding solution. Basically, this feature can automatically find and annotate all the spots on your TME slide. And last but not least, we have a three-dimensional reconstruction solution called 3D Peak. This solution can be used on confocal images. This means that if a confocal image has a lot of Z layers, based on these Z layers, the software is able to make a three-dimensional reconstruction of the digital slide, just as you can see it on this picture. Slide Viewer is an easy-to-use software. You can navigate the slide and you can zoom in and zoom out simply by using your mouse or your touchpad. If you are using a device with a touch screen, you can also use our touch gestures to navigate and zoom the slide. If you are a person who's used to the traditional controls of a microscope, we can supply you our slide driver device, and you can use this instead of your mouse or touchpad. In Slide Viewer, you can make visible the label area, so you will always know exactly which slide are you studying at the moment. It is also possible to see the original preview image from the scanner software. By comparing this image with the actual scanned area, you can see if you really scanned all the tissue from the slide. It could be useful to have an overview window, especially when you are heavily zoomed into the slide. In these cases, in our overview window, you can easily navigate the slide by clicking in different parts of this overview image or by dragging this rectangle. It is also possible to enable our tracking history feature. Tracking history highlights with the color specified by you which area was studied and which area still waits for review on the digital slide. Slide Viewer has a really rich annotation menu. We have here circular, rectangular, line, arrow, freehand annotations. We have annotations with a fixed size, such as 20 and 40x field of view. And we also have annotation with changeable sizes. By default, annotations placed in this viewer have dark blue color, and the naming convention is something like annotation 1, annotation 2, annotation 3, and so on. Later, you can change these in the annotation menu. But if you would like to place the annotations with the right naming convention and right color for the first time, that is also possible by making annotation scheme groups. For example, you can create a new group and you can add annotations to this group. You can specify the naming convention and the color of these annotations by using these special annotation groups, you can put down the annotations with the desired color and naming convention for the first time. In some cases, it could be beneficial to modify the brightness, contrast, and gamma saturation of the digital slide. This feature works on Brightfield and Fluorescent slides as well. It is important to note that in Fluorescent slides, we can also offer our customers an automated autofluorescence filter. After reviewing your slide, it is a natural request to be able to take some snapshots. In the viewer, you can quickly take screen-sized snapshots. These are ideal for easy sharing with your colleagues. On the other hand, if you need snapshots for publication purposes, you can opt for custom size, and you can set the size and the resolution required by your publisher or by your journal. As a separate feature, it is also possible to save snapshots in DICOM format. Probably the most important feature of the slide viewer is the multi-view feature. In my opinion, this is the killer feature of digital pathology, because you cannot visualize multiple images in the same time by using a microscope. But you can do this in a digital slide viewer, as you can see it on this slide. In our viewer, you can divide the canvas in 9 parts. This means that you can visualize up to 9 images in the same time. If you open consecutive sections, the system is able to automatically align them to the same zoom level and to the same orientation. And the end result will be that as you pan and zoom, you can see the same area from all the digital images. You can even put down an annotation on one of them, and you can clone this annotation to the other slides as well. Later, these annotations can be used for image analysis purposes. If you are producing TMA blocks and TMA slides, the TMA function feature could be quite useful. This feature works by means of image analysis. This means that you can use it on any TMA slide to detect and automatically annotate the TMA spots. If you are a user, one of our tissue microarrays, you can use the export files from these tissue microarrays in order to attach some sample or clinical data to the found tissue spots. I mentioned that the annotations could be the basis for image analysis. And in the viewer, you can easily access our image analysis tools from the measurements menu. In Quant Center, you can find several image analysis applications. My colleague will show you these in detail in later presentations. Right now, I just would like to give you a general idea. In Quant Center, we have general purpose applications which work on Brightfield and Fluorescent slides as well. For example, pattern quant or histoquant for tissue segmentation purposes. We also have a brand new script quant which allows researchers to run their own image analysis scripts, their own image analysis algorithms on the digital slides. We also have highly optimized applications for one single purpose, such as the nuclear and membrane quant for nuclear and membrane detection. And finally, we have genetic applications to detect mutations and chromosomal aberrations on fish and fish slides. When you have a slide management system, it is really important to have compatibility with other systems or other file formats as well. The good news is that our slide viewer software is able to open not just our MRXS file format, but also other file formats from other scanner vendors, such as from Apereo or Hamamatsu. If needed, we can even open DICOM slides with the slide viewer software. On the top of this, we can offer our customers a tool called Slide Master. The Slide Master tool can be used to import slides from third-party scanners in our Slide Center server solution. And you can store these slides in our Slide Center, and you can even run quantification on them by using our Quant Center application. This tool can work in the other way as well. You can export digital slides from our Slide Center server to a local drive as a third-party slide format. For example, if you have an image analysis application which doesn't support our file format, but supports another file format such as TIFF, by using this export functionality, you can run in the end analysis on your slide with a third-party application. Nowadays, I believe that a remote teleconsultation session is much more important than previously. Fortunately, in Slide Center, the user can set up a teleconsultation appointment quite easily in 3 steps. First, you need to add a title and a date for your teleconsultation. Optionally, you can also add some description, but this is not a must. In the second step, you can select quickly your digital slides, which will be the topic of the teleconsultation. Finally, you can add users or user groups to the teleconsultation. Basically, you can select which users will be the attendees of your teleconsultation session. When the teleconsultation is running in our slide viewer software, all the participants can see the same image in the same zoom level, in the same quality. All the participants have a small chat window at their disposal, so they can send short messages to each other. It is also possible to request control from the host. For example, if an attendee wants to make an annotation to show some objects to the others, and the host gives control for this attendee, then even an attendee can pan and zoom the digital slide and make the annotation. One can ask, what is the difference? Why is this better than another video call solution? And the answer is that our solution is better because in the viewer software, everybody can see really the same slide image in the same quality. This is not true for video calling solutions because those can alter and modify the video stream based on the attendees' network speed and processing power. It is also important to be able to easily share your slides with your coworkers or consultants. In Slide Center, you can share slides or case folders with other Slide Center users. The end result of this action will be that the slides will be listed in the share list of the recipient. It is also possible to quickly create a public share user and generate a unique URL to the digital slide or digital slides. You just need to send this link to an outsider, and this outsider can click on the link, and our instant viewer will automatically open the digital slide what you shared with him or her. This person has access only to the slide or slides which were shared with him or her, and has no access to the other parts of the system. The public share slides feature is really easy to use, and you can quickly share your slides with outsiders, with persons who doesn't have a proper user account on your Slide Center server. I hope that I managed to collect here for this presentation all the requirements about the slide management system. Please let us know if something was left out. You can type your comments and questions in the chat box. Thank you very much for your attention. We are waiting for your questions. Hello and welcome for everybody again. I don't see any questions in the chat window, so I would like to use this opportunity to thank you again for your attention. If you would have any questions later, feel free to write me to the email address which was displayed on the last slide of my presentation. Thank you very much. Goodbye.
Now we have a short break and we will continue at 4:30 Central European Summer Time. In the meantime, please visit our website and see you later. Welcome everybody back. After the break, we will continue with Róbert Paulik, the Development Manager of Research Image Analysis. He will speak about the differences between research and diagnostic use cases, the Quant Center as research image processing solution, and he will anticipate the new developments.
Welcome everybody. My name is Róbert Paulik and I am Development Manager at 3D Histech. Today I would like to talk to you about the image analysis softwares and software solutions for research use cases. First of all, a few words about the image analysis in general. What does it mean? Why is it important? The digital slide analysis could be data mining, for instance, correlation analysis between the measured data. We can create decision support systems. We can analyze the data with statistics, tables, and charts. Faster diagnoses are very important for pathologists, and we can create smart solutions for hardware and softwares. There are differences between the clinical and research use cases. In the clinical use case, the staining and the tissue-specific solutions are more important. The algorithms are validated and approved. The analyses are made mainly on field of use. One of the most important aims is the faster diagnosis for pathologists, and we can create decision support systems for them. In our product line, the image analysis is integrated with the case manager and with the clinical viewer. In the research use case, there are different tissue types and multiple stainings. So we need universal and flexible algorithms. The algorithms are executed on whole slide, and one of the most important aims is to support the research study and research use cases. We can create statistics, tables, and data mining. The slide supports are usually local or remote. What does mean the research projects? It's a list of slides where the research method is previously defined. The quantification results are stored in the slides or in the cloud, and we can create cumulative or multi-slide statistics. We can analyze these data with data mining, and we can create charts exports. Our research image analysis software is the Quant Center application. It's a flexible slide quantification framework which contains multiple quantification modules. These modules can be hierarchical. We can adjust the region of interest, annotation, whole slide, or multi-slide. It contains a lot of tools for statistics and data mining, and it contains advanced features for bioinformatic users. Our research method is called as scenario in Quant Center application. It's a portable method definition. It can contain multiple quants at the same time for hierarchical analysis. For instance, analyze nuclei in tumor region. We can create and define multiple clusters like cancer, stroma, background, and we can classify it with these clusters. We can adjust the filtering and other parameters. Fast preview is available during the method definition. The first and probably the most simple quant is the density quant. It's an algorithm for staining intensity analysis. It's easy to calibrate since it contains automatic color deconvolution algorithm. It can provide you fast results and statistics. The nuclear quant is made for nuclei detection. It supports Brightfield slides, and it supports estrogen, progesterone, Ki67 stainings. It's IVD approved. The membrane quant is for membrane detection. It also supports Brightfield slides, and it mainly supports the HER2 staining. It's also IVD approved. The cell quant is one of the most researched applications. It can analyze the cell compartments together, the nucleus, cytoplasm, and membrane. We can combine these algorithms to analyze together, for instance, the nucleus and membrane. It supports fluorescent and Brightfield slides. The HistoQuant is an intensity-based area detection algorithm. We can define multiple clusters inside it, and we can analyze the colocalization with the intersection of two clusters. It supports ASV, HSV, or RGB channels, and it also supports Brightfield and fluorescent slides. The pattern quant is our machine learning tissue detection software. It uses pattern recognition algorithm. We can create multiple clusters, and like the HistoQuant, it also supports HSV or RGB channels. It's for Brightfield slides, and it's a trainable algorithm. We can train it with user-defined ROEs. The FishQuant is made for analyze the fluorescent in situ hybridization, staining, and slides. It contains a combined nuclear and spot detection algorithm, and it contains a lot of predefined clusterers for probes. It has support for secondary probes. The probe list can be user-defined and modifiable, and it's also IVD approved. The Pattern Quant Plus is one of our latest development. It's a new tissue detection algorithm. It was introduced in Quant Center 2.3. It's an area detection algorithm where the features can be multiple and can be user-defined or user fine-tuned. It uses superpixel-based detection and classification. It supports the deep learning since we can train with multiple slides. In the background, it uses a decision tree-based clustering. Our second new development is the scripting feature. It's also introduced in Quant Center 2.3. It's a new way for image analysis. A script can be an algorithm which is user-defined for image processing. It extends the possibilities of our quants. It's made for special studies or special researches. The target audience is the hardcore researchers, developers, or bioinformatic users. The scripting is first introduced in the script quant. The script quant supports the Python as a main programming language, and because of the Python, we can use a lot of libraries like TensorFlow and OpenCV for image processing. The script quant supports the Visual Studio Code as the main programming environment. And during the scripting, the user can get a fast visual feedback. When we type the code, we immediately see the results of it. It has a documented API, and it has a lot of examples. It has a lot of developer tools. A few use case examples for the script quant. The first can be the detection use case. It means segmentation like nuclei or tissue. So we can create a nuclei detection algorithm by a Python script, with a Python script. We can adjust the clustering, the zoom level, number of threads for processing. The second example could be the AI instance, artificial intelligence, where we can use pre-trained models, for instance, TensorFlow models for prediction and for image analysis. And we can store the results back to the slide, and after that we can render in the viewer. The third instance is the statistics. We can analyze the slide and we can export the statistics from the Python script to, for instance, XML, JSON, CSV, XLS. Or we can export the objects, for instance. The last instance is the integration. We can create a script which calls a server, an external server, or calls an external applications, sends the image and receives the results from the server, and saves the results back to the slide and renders in our viewer. Quantification result. The quantification process is made in the background in a separated process, so the user doesn't need to wait for the processing, especially in case of multiple slides where the analyzation can take a few minutes. Result visualization, card view, it's an overall statistics. It's the on the right side of this slide. Or tree view, it contains detailed statistics about the quantification result. The result is rendered back to the slide as an overlay, and we have a lot of features for export the statistics into XLS, CSV, or XML file. The data visualization tool is a data mining tool for analyze segments and objects, measured parameters. We can analyze with tables, we can create charts, scatter plot, pie chart, histogram, clustergram, histoplot, accumulation table, and so on. We can adjust the filtering between the objects. And as I mentioned, it contains a lot of features. We can export features. We can export images, objects, and charts. It contains a relocalization feature. When we select a nuclei, it shows the exact position on the slide, and we can see the environment of this cell or nuclei or any other type of objects. Currently, the Quant Center 2.2 is available on the market. The Quant Center 2.3 will be released in June in this year. It contains a lot of optimizations, bug fixes, and there are two new quants, the Pantan Quant Plus and the Squid Quant. Thank you for your attention. I'm waiting for your questions. Thank you.
Welcome again. We haven't received any questions during my presentation. If you have any further questions, please write an email to me. Have a nice day. Goodbye.
The next speaker is Dr. Yukako Yagi, Director of Pathology Digital Imaging, Department of Pathology at Memorial Sloan Kettering Cancer Center in New York. By now, more than 30 companies in the world have been working on AI in pathology. How we can implement AI and image analysis application into clinical workflow is still under investigation. She will introduce their ongoing project in breast cancer as a use case. They are using Quant to integrate their AI application into one of their clinical WSI viewer. They have just started integrating their AI application of Python scripts into one of their clinical WIS viewer. The mechanisms of data management of image results, training, and clinical data are still under evaluation. However, their finding could be very helpful for both vendor side and user side. Dr. Yagi, please take your presentation.
Hi, I'm Yukako Yagi. So thank you for organizing this virtual symposium. So I'm from Memorial Sloan Kettering Cancer Center. I'm the director of the digital pathology, the Warren Alpert Center for Digital and Computational Pathology at MSK. So I'd like to introduce how we can implement in-house AI image application in clinical, and we are still on the way for the implementation, but it might be helpful for someone who has own AI application like us. So AI in pathology is getting very popular, and I heard more than 30 companies in the world have been working on AI in pathology. So not only industry, like us, academic people also have been working on AI and image analysis application development. So the question is how we can implement AI and analysis application in clinical workflow for pathologists to take advantage of this AI technology. So we have to use an application in the whole slide imaging viewer integrated in the laboratory information system. So I'm going to introduce our ongoing project in breast cancer as an use case. So before talking about our project, I want to introduce about Memorial Sloan Kettering Cancer Center and our digital pathology activity briefly. So because it explains why we are doing the project and I'm going to talk. So MSKCC is a 500-bed cancer center in New York City with a large pathology department, including over 160,000 accession cases per year. So because of the size of the hospital, we have many slides to store, and we keep slides of last 5 years in-house, and the rest are off-site storage. So about 5 million slides are on-site, and about over 25 million slides are off-site. So we have started scanning slides in late 2015 from one scanner, but this activity was rapidly growing. So now the monthly scanning average is 100,000 slides. So we have 25 high-throughput scanners and 22 staff members at 6 locations. So depends on the slide type and also the application, we use different scanners. So for breast project, we are using P1000 3D History, and Also, the other area we really need high quality of image, we usually use P1000. So at the imaging lab, so our lab has been working on basic technology development to improve whole slide image quality and consistency. Also system development, working with industry to collaborate, and also multimodality imaging. So all applications are toward to clinical. And breast project is one of the applications. So this project is assessment of HER2 amplification status in invasive breast cancer using Brightfield in situ hybridization and digital pathology. So we started to support only CISH. Then later we applied on FISH slide, and also now we try to implement IHC as well. So HER2 positive breast cancer is a poor prognosis disease. HER2 test is important for prognostic and therapeutic decision. So therefore, it is necessary to quantify and detect HER2 amplification in invasive breast cancer. So there are three testing methods for HER2. So IHC, FISH, and CISH. So IHC is qualitative or semi-quantitative approach, while ISH is a quantitative approach. So IHC is cheaper but could not be conclusive and accurate always. And depending on the IHC score, FISH evaluation is performed. However, FISH evaluation requires fluorescence microscope, and it is labor intensive. So for the last couple of years, we have been evaluating CISH to replace FISH. So this is a CISH staining image with the pathologist count signal of HER2, the black one, and step 17 in pink, per nuclear at least 20 per slide. So then calculate the ratio. So this is still labor intensive, so therefore automated system was requested. So the workflow of initial system is here. The formalin fixed paraffin embedded block a section with automated sectioning machine, so that we can obtain good quality of serial section for automated dissection of ROI using the corresponding H&E slide. Then the slides are stained and scanned with 3D Histech P1000 scanner. HE slides are scanned with 20x, and CISH slides are scanned with 40x, 0.13 micron per pixel resolution. And to move to clinical application, so we are not using this automated sectioning machine because it is not FDA approved machine yet. So Microscopy is the in-house application for CISH. It is a standalone system, so it it was required to export ROI and submit to this application for analysis. This is example of exported and imported image to application. So this is what this application does. So signal count result image and also showing the result of nuclear detection. And also HER2 signal and CEP17 signal detection result is showing. And the pathologists can confirm visually if they want. So application results are not always perfect, so pathologists can remove or add nuclei if they want. So it is a very important feature as a clinical system. We also generate case report of CISH analysis. So at the USCAP conference last year, so we presented about our result. So the result was very promising. So most of the cases correlated automated between automated analysis and manual counting. To make it more reliable, we implemented machine learning for single nuclear detection. So because there are many overlapping nuclei and it made us difficult to segment good nuclei for analysis. So at this time, applications support HER2 FISH as well. So to confirm CISH and FISH correlation, we prepare new H&E CISH and FISH slide. And we modify the application to support for FISH and FISH together. So after implementing deep learning unit into nuclear detection, the system of nuclear detection was improved. So current system architecture is shown in this figure. So pathologists annotate invasive cancer area on H&E, and the same area of CISH and FISH are analyzed automatically, then reports are produced. So automated invasive area segmentation is still under development, but the pathologist annotation is helping us to develop better quality of automated invasive area segmentation and detection. So we don't have a 2P panoramic P250 scanner in our institution, but if this application can support both images. It summarizes how the application works for both CISH and FISH. So by now, we have validated over 100 cases, and the results are very good, enough to move to clinical. So we have published early stage of our result in this paper. So however, standalone system is not ideal as a clinical application. So it has to be able to be used with LIS and analyzing in the whole slide imaging viewer, which pathologists using regularly. And also pathologists asked us to use the application for IHC analysis. As a possible solution, so like we try to find the best and easiest way to do it. So 3D Histech case viewer is one of our whole slide imaging viewer integrated in laboratory information system. So we asked 3D Histech, so can we make plug-in like this? And also, can we use Quant Center for IHC analysis? So the reason we had to develop fish and fish ourselves, we worked with the lab and pathologist and imaging lab to have stable staining and image and the result. So in-house application is more suitable for this situation. But IHC stains are already stable and standardized internally, so commercial application may work better. So Script Quant was introduced as one solution. So Script Quant so it is a possible gateway for AI developer like us, and our application written with Python. It's very suitable for us. And the most importantly, actually, we can use all case viewers feature in our application, such as annotation. So and analyze the area without any exporting process. That's really helpful for us. So how we can use it? So from case viewer, it's the latest version of case viewer named slide viewer. So the case viewers, we open Quant Center. We can find the Quant Center icon is here. So application Shimaris Pack can be added as a part of Quant Center. So we are using combination of existing application of Quant Center and Shimaris. So Quant Center for IHC analysis. We have the set of IHC analysis in the Quant Center, and H&E and fish and fish we use in our Shimaris application. So as an example of result, so we evaluated fish and fish using our Shimaris, and also manual counting and by pathologists as part of validation. So all scores are correlated well, and we adding now the IHC, Hajdú IHC to use membrane quant. So the result of Shimaris quantification result, the example of imaging, detailed images. And the system can show the result in the screen and also export the report as Word file. Exactly same feature with standalone Shimaris system. And this is the result of fish quantification. So it is the result of a membrane quant for Hajdú IHC. So the result was the same score with the clinical report and also fish and fish. So you can see the high magnification image to confirm the result. So the pathologists are reviewing the result of membrane quant, and so far they like the result. So once we have invasive cancer segmentation, all the process, including IHCs, will be almost automated. So result of Quant Center, including Himalays, have to be managed well to connect clinical information. So we are planning to use enhanced multimodal database we call 1DB to bridge research data and clinical data. So also, we have another application for automated 3D fish scoring, particularly for break-apart probe. So this application also written with Python. So in the future, we'd like to implement this application also into case viewer. So for this application, actually we had to develop the viewing part, the view whole slide imaging viewer part by ourselves, but we can't make the viewer like case viewer. Very nice to view whole slide image. It's very hard for us to develop, so we can focus only the part to segment and count the nuclear and signal. This is the concept of our application. This is for break-apart probe. So we are evaluating 3D data, like G-stack images. It's a summary. So API such as Script Quant play an important role in the clinical integration of AI and image analysis application. So Script Quant and Quant Center allow us to spend less time on GUI development and or common application development such as IHC and focus more on algorithm development in critical case areas. And we have just started integrating our AI application of Python script into Quant Center. The mechanism of data management of image result training and clinical data are still under evaluation. However, our findings could be very helpful for both vendor side and user side. And we are also working on expanding to fish break-apart application. I'd like to acknowledge the Warren Alpert Foundation for supporting our research and 3D History for supporting this presentation. And also I'd like to thank to all my lab member and collaborator and Warren Alpert Center member. Thank you. Yes, thank you for listening my presentation today. So I have two questions. So one is how many J-layer was used for scanning fish slide for 3D image evaluation? So for particular this fish, break apart fish, actually we used 7 layer. But for Hajdú fish, actually we used 5 layer, then used extended focus to analyze. So it depends on the purpose we change, we optimize how to scan. So again, like for Hajdú fish, we used 5 layer and extended focus to analyze. But for break apart fish analysis, we scan with 7 layers and kept the G-stack. So we analyze as 3D. And the second question is what are your expectations for the future? Actually, yeah, so we want to integrate our own AI. Also, like we cannot develop everything to support pathologists. So using some other like vendors AI application or some other group's AI application. So we want to use in clinical when pathologists sign out cases. So to do that, actually, like his Quant script Quant, that kind of a system is very helpful for us to use it. So in the future plan, actually everyone using whole slide and also AI application for diagnostic to support the diagnosis. The question 3. I have more questions. Thank you for many questions. What is the average tissue size for the G-stack, G-layer scanning? If we speak about the thickness of the average tissue, actually thickness of tissue, actually we have a protocol with section 4 micron. The area size for Hajdú fish, we scan maybe only some area. So sometimes some of the case we scan entire area, entire tissue, but most of the case maybe I don't know how big the area, but only invasive part of one part of invasive area, most diagnostic. So question 4. This is the last question. So sorry. So thank you for listening and have a nice day. Goodbye.
Our next speaker is Huba again. You already know him well. He will talk about the TMA and show some videos about the TMA workflow. Huba, please give your presentation.
Welcome everyone. My name is Huba and I am the TMA Product Development Manager at the 3D Histech company. Now, I would like to talk about the TMA workflow and data management. Let's see the agenda. First of all, I would like to introduce shortly the TMA technology for the beginners who maybe never heard about it. Then, I will tell you about the advantages of TMA and the possible users and institutions. Next, I'll show you the 3D Histech solutions, and we will see how to make a TMA block. We get to know our instruments and its control software. After that, we gain insight into the TMA database via our data management software. What is TMA? TMA means tissue microarray. The TMA technique can be used as a valuable high-throughput tool for research and diagnostic purposes. By being able to place up to several hundred different samples into one paraffin block. Tissue cores or organ cylinders are extracted or punching from paraffin-embedded tissue blocks. We call it donor blocks. And then arrayed these cores into an empty paraffin block, recipient block. You can see the format of the donor block and recipient block are the same. So you can sectioning the recipient block like a donor block and put the slice to a glass slide. Stain it with, for example, very expensive reagent, dry it, cover it, and scan it. Then the TMA digital slide is ready for the image analysis. Thanks for our high-resolution scanners, this small part of the tissue are enough for the analysis. For example, the diameter of the spot may be up to 0.6 millimeter. Let's see the advantages of TMA. With using TMA can save time, reagent, tissue, slide, workforce, and of course money too. Who use TMA products? Who are the possible customers? Biobanks create and sell custom-made TMAs for academic research, pharmaceutical research, other research laboratories, pharmaceutical companies, pathology departments in hospital for diagnostic. For example, in the picture, you can see a slide with a big tissue, and in the corner there is a small TMA with the same staining, which help to make the best diagnostic. Other customers can be antibody and probe manufacturers too. How to make a TMA block? The simplest method to make a TMA block is the manual method. Simple and cheap, but not easy. I tried before. It takes a lot of time and the quality is lower. You need to document and so on. There are several semi-automated TMA machines in the market too. But the best way to build a TMA block is use the computer-controlled full automated TMA instrument. The 3D Histech has developed only that type of devices. We have two different TMA instruments, the TMA Master and the TMA Grandmaster. The TMA Master block capacity is 5 blocks, and the Grandmaster capacity is 72 blocks, 12 recipient blocks and 60 donor blocks. Both machines use the same toolset, puncher and driller set. The diameters are 2, 1.5, 1.0 and 0.6 millimeter. If you choose the smallest diameter size, it can be inserted more than 500 cores into a recipient block. Both TMA instruments can be controlled with the TMA control software, which we are constantly developing. The following preparations are required to create a TMA block. We can make the empty paraffin blocks, the recipient blocks. We only need to have plastic cassette, paraffin wax and molding form. Then the necessary donor blocks need to be selected. If we have an Excel file which contains these donor blocks IDs and any other medical information, it could be very useful in the beginning and later too. This list can be imported into the TMA software. I will show you soon. And it can be saved to the TMA database too. Each donor block must have a flat surface in order to produce the best quality TMA blocks. It is true for the recipient blocks too. So we have to cut off all the blocks. Otherwise, if we make a glass slide from these slices, we could use them too during the TMA process. If each donor block has got their own glass slide, then these can be digitalized with a digital slide scanner instrument. Let's see the TMA workflow. Now the slides are scanned to the slide center server and we can start the annotation process. Open the slides with the new slide viewer software and we can use the new quick annotation tool. Previously I created a TMA annotation group, and now I just need to load this group and select the right annotation, and with a single click it can be placed on the slide image. And I repeat it step by step, slide by slide. First step is to create a new TMA project, and then we put the blocks into the TMA Grandmaster, both the recipient and donor blocks. After the blocks are inside, the instrument checks it and takes 2 photos per block, one from the block surface and the other one from the label area. Then we name the recipient block with a unique identifier number and create a layout with the layout editor. It can be adjust the number of the column and row, the gap between the cores, alignment, and filling direction too. Okay, we are ready for our layout. Next step, we give names to the donor blocks. There are 3 different ways. The first is the simplest, just type the ID. If the donor block label contains barcode image, then the software automatically recognizes it. Or if we have an Excel file which contains the donor IDs and any other medical information, then it can be imported into the software. And we can save it to the database too. After that, the right name can select it from a drop-down list. Now, each block has got a name, so we start to find their digital slides. The software automatically finds the slides, loads them and rotates. If necessary, the slide rotation can be improved manually. Several settings options are available. The slide image can be moved, zoomed, and flipped, or 3 reference points can also be used for a more successful result. This request came from Glasgow, for example. Thank you. Okay, after all blocks match with their annotated slides, then the final task remained. We can put the TMA markers. Here the filling direction on the recipient layout is from right to left. That filling direction option was asked from Arabic area. So if you have any other feature request, suggestions, or idea, don't hesitate to contact with us. And finally, push the start button. Now we will watch a video about the TMA Grandmaster. The TMA block is ready, and with the magnifier tool we can check the success of the core insertions. Each core links with their donor block, their slide, and their spot slide too, which came from the rotated slides. It can be open with the slide viewer software. We haven't even taken the block out of the machine, but we still have a virtual slide of it. Now we change the view to spot slide view. The donor block image can be open too, as you can see, and the software saves the slide image, the annotation layer and the TMA marker layer to the database. The matched slides can be opened with the slide viewer too. And from the TMA control software, each recipient block data and each donor block data can be displayed. Now we will see how to create an Excel export file. All data is saved automatically to the database. And of course, any individual TMA projects or recipient blocks data can be exported to an Excel file. There are 4 different views and it contains many hyperlinks to the images. With a web-based viewer, all images can be checked. Now we can see our latest project with the donor blocks and the recipient blocks. Now I would like to show you the TMA register software, which is available from the latest releases, but from the next release it will be a separate software that can be installed to any Windows computer. So it will be run not only the TMA control PC, so the TMA database will reachable from anywhere. This is the TMA register software. First of all, we are looking for our latest project, then select the recipient block from it. So now we would like to define slides from this TMA block, need to write the names of the slides and any other important information. Easily new columns can be added, for example, staining data. And after these TMA slides are made and scanned to the Slide Center server with the right name, the TMA register automatically finds these and create a link to open. Let's try it. Here we can see the TMA slides in the slide viewer. And here is the other one. Next step, the software will separate the spots from the TMA slides and save them separate spot slides. In the background, an automatic spot finding algorithm is running, and after each spots are finding, then link them with their data and save it to the Slide Center server. Now we can see them in the Slide Center and open. With the multi-view function, we can see the spots next to each other, and these two spot slides came from the same TMA core. Thank you for your kind attention. We will continue with the Q&A section. Unfortunately, there is no question. It was a great pleasure for me to make this presentation. I feel myself like a warm-up rock band who can play before the Guns N' Roses. But now, please welcome one of the rock stars of the TMA from Switzerland, Inti Zlobec.
Now we have just arrived to our last topic and presentation. Professor Inti Zlobec works as Associate Professor at the University of Bern, where she leads the Translational Research Unit, a research platform specialized in tissue-based research, including digital pathology. Their Translational Research Unit has developed next-generation TMAs that represents a process of TMA consulting, followed by slide scanning and digital pathology, as well as rapid, precise, and automated TMA construction.
Hello, everyone, dear colleagues, ladies and gentlemen. Thank you very much for being here with me today. And a big thank you also to Dr. Molnár for giving me the opportunity to talk to you about a topic that I love to talk about, which is, of course, next-generation tissue microarrays. And today I will go over some of those applications and show you some of the novelties that we have here in NGTMA. So the first thing I'll talk about is what is NGTMA. Secondly, I'll have a look at some of the more classic examples of where we've been using tissue microarrays, especially NGTMA. I'll also be looking at some of the trendy areas that we see popping up for NGTMA, and finally look at some computational challenges. So let's start from the very beginning. Pathology is really a pillar for personalized medicine, and everything begins with the patient. And more specifically in pathology, it begins with the tissue. This tissue, which is processed into tissue blocks, and then these blocks are cut, stained, and then the pathologist will evaluate these stainings and these tissues under the microscope. And from there, they can get an idea, or they make a diagnosis, they get an idea of prognosis, therapy responsiveness, and of course, get to see that tissue as a snapshot in time, undergoing certain biological or disease processes. Digital pathology, of course, goes one step further, where we take these slides and digitize them in such nice scanners, and then afterwards, these images can be evaluated on the computer screen. And if you have those images on the computer screen, you can do a lot more. You can also have, for instance, the application of AI to those images to either extract features or be able to classify different tissues into different, for instance, molecular subtypes. Now imagine being able to create tissue microarrays on the basis of digital pathology. So if we look at this image, which contains a huge amount of information, I would like, for example, to be able to create a tissue microarray of a very specific region. In fact, this area here, directly at the invasion front of this colorectal cancer. In fact, that's sort of the history of the NGTMA story, where we were actually interested in looking at tumor budding. So these single cells that can be found exactly in such regions that have a very strong correlation to poor outcome. Using a classical tissue microarray approach, being able to target such an area for inclusion into tissue microarrays is actually difficult, if not impossible. But if we would have a digital image, we would be able actually to make an annotation on that particular area and punch that particular one out. So next generation tissue microarrays are on the basis of digital pathology. So a slide that is scanned that can be then annotated in different regions. For instance, here we have normal tissues in green, perhaps the center of the tumor in yellow, and in blue here, the invasion front or areas, for example, of tumor budding. This slide that has been annotated can then be aligned to the tissue block from which it derives, and that alignment is done using machine learning algorithms that are continuously being improved so that there is as little fine-tuning manually that is required to make such a perfect match. Then each one of these punches, or these areas that have been annotated, is then punched out and transferred into an empty paraffin block. And if you do this over and over and over and over again, you basically create yourself a beautiful archive of very specifically chosen areas that come from the digital pathology environment. And of course, if you multiply these particular tissue microarrays and you create what we would refer to as copies or duplicates, triplicates of that particular cohort that you're interested in, And if all of these different tissue spots are actually annotated together with clinical information deriving from these patients, then you can have a very, very powerful tool for research. So here's an example of a tissue microarray that is being constructed. On the left-hand side here, you see another colorectal cancer. All my examples are pretty much in colorectal cancer because that's what I do research on. But you can see these different areas that are annotated in these different colors, and in fact, different sizes as well. And I'll show you what these particular punches that are a little bit larger, what they went into in a second step. Here's an example of the annotations that can be seen or visualized on this block. The slide that has been annotated and the block are then aligned in a first step almost perfectly, but then some fine tuning can in fact be done in order to perhaps, if there are issues related to stretching of the slide in a water bath or anything like this, that can then really just be corrected. And then in a second step, you'll see here that once this is, well, considered a perfect alignment for us, these annotated areas then show back up onto this block, and then we can punch out those regions and create for us a beautiful tissue microarray. In the meantime, our NGTMA facility has produced more than 800 different TMA blocks and has included more than 150,000 actual physical punches within those TMA blocks themselves. We have these two machines that are creating those tissue microarrays, and in the meantime, we have collected a quite large archive of not only tissue blocks, but as you can imagine, immunohistochemistry stainings coming from those blocks and everything that we have scanned over time. So just here on the right-hand side, you get to see a little bit the distribution of the kinds of tissues that form part of our archive. So let's go over some classic examples of what we would use the NGTMAs for. So what do we use them for? It sort of depends on the question and sort of depends on what the researcher is really interested in studying. So we have a lot of topics that come from precision medicine. For instance, screening large numbers of tissues for particular biomarkers. And this is always somehow, this is like the origin of the TMA. It was made to be able to have a look at different biomarkers on a large number of tissue samples. So we can do that, of course, with NGTMA. Also to correlate biomarkers with outcome, which is, of course, a large, one of the major questions when it comes to precision medicine. So is the expression of particular biomarkers correlated with more aggressive disease, with response to therapy, etc.? We also use the tissue microarrays in order to study correlation between different markers themselves, or to study, for instance, rare diseases or scenarios where it's not perhaps recommended to cut down the whole tissue block in order to study different biomarkers. So we can take out punches from those particular rare disease tissues in order to study them. We study tumor heterogeneity using tissue microarrays. It used to be that the problem of heterogeneity was one that was always used against TMAs being appropriate for certain studies. But we've actually learned over time that we can study heterogeneity by creating very smart tissue microarrays that are taken with multiple punches from different areas across the tissue and still have this as a very valuable tool. We target histological areas, as I was showing you before, those specific areas like, for instance, those at the invasion front, which might produce a lot of very rich information that comes from this whole meshwork of cells that's working together and being very coordinated. We perform animal studies, so we do xenograft TMAs as well, and also TMAs of cell lines. So here are some pictures and also publications that come from the use of NGTMA. So we sort of have the classic scenarios where we have immunohistochemistry. We perform a lot of double immunostaining in our lab. So this is what you're seeing here in brown and red. We do immunofluorescence. So here again, double immunofluorescence using these colorectal cancers. So here, this was a study looking at cytotoxic T cells. So looking at CD8 and PD1 co-localization and with regards to immunotherapy. Here's a study in pancreatic ductal adenocarcinoma where we're looking at, or we've used methodologies that include mRNA in situ hybridization or fluorescence in situ hybridization. And here's an example where we're using very rare material. This was a collaboration with Doug Hanahan's group in Lausanne, where we're looking at breast cancers and their brain metastases. So very select group of patients, very important to study. And so we're able to collect those and put those into tissue microarrays as well. This is somehow a very interesting thing that happened recently. So we were creating a tissue microarray of apparently triple negative breast cancer. And this is a very large cohort of triple negative breast cancer, beautifully clinically annotated data that corresponds to these different tissue samples. And we, of course, did a panel of standard biomarkers for breast cancer on this triple negative array, including estrogen receptor, progesterone receptor, and HER2. And you can see, even from such a distance, that there are a few samples here. This probably belongs to the same patient, and this belongs to the same patient. There are several patients in this apparent triple negative breast cancer TMA that are not, in fact, triple negative. So it gives you an amazing glance. So at one glance, over hundreds of samples to check for different biomarkers. So let's talk about some of the more trendy applications of NGTMA. And you're going to see a lot of colors in the next few slides. Establishment of different methods using tissue microarrays in order to be able to study, for instance, or to use methods that are very expensive on very particular areas within tissues from patient cohorts of high specificity is something that we see as coming out as very important. Here's something that we have done ourselves where we were interested in trying to accumulate information from different biomarkers. In this case, we have 3 different biomarkers at one time on a particular spot of TMA. And this was actually done in order for us to capitalize on the next step, which would be image analysis, in order for us to be able to get a more easy, let's say, separation of colors in an image analysis step. So here we have, for instance, in brown, the cytokeratin, which is, of course, pointing to epithelial cells or tumor cells. We have in red or pink, the CD8 positive T cells, and in green, macrophages. So this is something that we are now performing in the lab as sort of an established protocol. Also, something new that has come out are these short RNA sequences that can be analyzed using in situ hybridization methods, like BaseScope here. And this is, for instance, a method that will be able to pick up very small sequences, so 30 to 500 nucleotides. For instance, looking at splice variants or some sort of very short non-coding RNAs, for instance. And this can actually be visualized using tissue microarrays. And this is what we've also established in the lab for particular projects looking at these kinds of non-coding RNAs in cancers. We also can combine different kinds of methodology. So this is a tunnel staining, which is picking up basically the DNA strand breaks, which are leading then to apoptosis. And that's what you see in green. And in red, you have CD68, which is again a marker for macrophages. And you can see how the two things are really basically co-localizing together. So again, combining different methodologies to study very particular questions using NGTMAs. Now, multiplexing is something that is, of course, hugely important in research. It's a very new method. It can be done in numerous different ways, and we're very happy to say that many of these have already been applied to our own material on NGTMA. So for instance, here is an example of imaging mass cytometry. So we would have our TMAs that have been used or sliced onto these tissue slides, and antibodies that are then labeled using heavy metals. And these metals are then basically, so a laser is capturing the different areas of the tissue. And because these are labeled with metals, the signals of the different proteins can actually then be, of course, split, and using mass cytometry then can be analyzed. And then you see how those images can then be co-registered together and then produce information that can be in the dozens of multiplexed proteins at one time. And here are actual images from mouse spleen that we were able to create an NGTMA for, and using the Hyperion here at the University of Bern. Similar technology, but a bit different, still multiplexing. In this case, it's not heavy metals that are attached to the antibodies, but these are barcodes. And these little barcodes, of course, act as unique identifiers to the antibodies that are being put onto the TMAs. This is not our own TMA, I have to say, but just to show you that this can be a very nice application to TMAs. So those signals that are basically attached to these barcodes are then amplified and then can be detected using fluorescent methods. And you can see here how, again, you can get a very nice picture of multiplexed images using tissue microarrays. A third possibility is not necessarily to attach either barcodes or metals to different antibodies, but you might have a cyclical way of analyzing, let's say, antibodies 2 by 2. And in this case, this is a microfluidic technology that basically allows very short reaction times to occur because the distance between the reagents and the tissues is minimal. And so here we have a cyclical way of analyzing 2 antibodies at a time, and then again 2 antibodies at a time, and so on. So this can then be built up and possibly can lead to a very large number of proteins that in the end can be, again, co-registered and plexed together. And this is technology from Lunaphore. So here we have different examples of, let's say, increasing levels of complexity. We're getting into the whole domain of computation. Here's an image from our lab. This is, again, from the tissue microarrays. We're looking at colorectal cancers. And I love these images because what you can see here is in blue, pancytokeratin. In red, we have a nuclear identification, so marker for nuclei. And if I could just draw your attention to this set of nuclei here. So what is going on here with these 2 little blue pieces next to this red cell? And we then add another color, which is green. In this case, this was supposed to detect CD8 positive T lymphocytes. And here we can see that this particular cell was not affected by this. And now we add the marker for CD68, which is a marker for macrophages. And you can actually see that this is very likely a macrophage that has engulfed a tumor bud, because we can see these 2 little pancytokeratin fragments, let's say, within this macrophage. And of course, this is something, as a person who loves to study tumor budding, I find this absolutely fascinating. We can go one step further to take that information, start to perform proximity analysis and see what is, for instance, the distance of particular clusters of these different CD68, CD8 positive T cells, and how can we visualize that in terms of distances away from the margin, for instance, and start to get the idea of particular clusters that might be surrounding the invasion fronts, for instance, of colorectal cancers. So we're starting to include here machine learning. Here's an example from another technology used for multiplexing, and this is called multiplexed ion beam imaging. This is from our colleagues at the Weizmann Institute in Israel, and they're performing this now using different tissue types. So again, a similar method to Hyperion that we were showing or talking about before. And now you can see how beautifully these images can be captured. And not only that, but that we can perform, for instance, neighborhood analysis. So again, we can look for what these different cells, or what are the neighbors of the different cells, what kinds of proteins are being expressed by those neighbors, and start to identify clusters of those particular cell types that are attaching themselves to each other so that they form neighborhoods in space. And being able to study those neighborhoods in space and how they interact with each other, one can then add this to clinical information and then have a very detailed view that could be used for patient stratification. Our own example here using Codex, this was a study that was performed to try to look for differences in proteins. We used 56 different antibodies that were applied to tissue microarrays that were looking for differences in how the arrangements of lymphoid follicles were made in the Crohn's-like reaction, so really follicles of lymph nodes in colon cancer versus the diffuse cell infiltrates that we very often see as peritumoral inflammation around the invasion front. And by performing a sort of sliding window approach, you can create a huge amount of information, study the different relationships between different cell subsets, and in the end, come back to the actual tissue and make conclusions about what we're seeing in these different kinds of lymphoid aggregates. We also have this multi-regional mapping that can be done. So as I was mentioning before, those big black circles that we have on those images that were a little bit bigger were not made for the TMA. They were made to punch out tissues to be able to put them as cores into these little tubes, and from there, targeted RNA-seq can be done, and phylogenetic studies can also be made. Over time, we have accumulated more than 1 million tissue images, so spot images or whole slide images in our TMA archive. And now we can, of course, use that for training of AI algorithms. And we have also published our first such algorithm to detect colorectal tissue or tumor, actually different kinds of tissue, using 15,000 of our own TMA spots from H&E of colorectal cancer. So very powerful tool. And here just a final example where we could actually use our tissue microarrays and incorporate image analysis solutions directly in. I picked a very specific spot here that had a chromogenic artifact on it. What we can easily do now is integrate different image analysis tools into our database for where we keep all of these tissue microarrays, because they have to be all connected together, and actually perform image analysis right away on these different tissue spots, depending on the tissue type. And for instance, here, this is such an example where we can then play around a little bit with what we're seeing on the screen. Oh, I should mention that as of today, we have more than 100,000 images in our research database on TMAs. So NGTMA is a hugely powerful resource. It can be used still for the classic examples, for method establishment, and helps a lot with cost reduction issues. It can create beautiful image archives that can lead to training cohorts for AI, and the integration of all this image analysis, these tools, and streamlined pipelines for data handling is, of course, where we are going right now. So many thanks to you for listening to this talk today. There are many people involved, of course, in the success of NGTMA and our whole digital pathology project here at the Institute. Many thanks for your attention, and I hope I'm not too late with my time. Thank you. Okay, so welcome everybody. Thanks to all of you who are still online attending at the moment. So I have a couple of questions that were sent to me, and I will just get started on those. So one question is, what is the size of the TMA spots used in your experiments? So normally that really depends on what the question is. So for example, if we do something like a screening of different biomarkers across the TMA, then maybe we will use something like 0.6 millimeters for that. Or if we're interested in something that's more like the tumor microenvironment that we're interested in, we've discovered that if we use a little bit bigger cores, so maybe of 1 millimeter or 1.5 millimeters, then that you can capture a lot of information with that. So that's somehow some of our ideas regarding that. We've also done animal organ type of TMA, so on mice, and so they would require maybe even a larger size, so up to 2 millimeters. So essentially, it really depends on what the question is, and that's sort of the whole idea of NGTMA, is to really be able to target exactly what the researcher wants. And that's a bit of a different question than, when TMAs were really starting, also in the late 90s, the idea was just to cram in as many tissue spots as possible on a single slide. And then to do like screenings. And we still do screenings, but actually the aim of the TMA is quite different now. So it's really to construct, a TMA that's perfect for the question that needs to be answered. So it really depends on what we're doing. So question number 2 was, any tissue block can be sampled for RNA-seq, or Is there a special fixation procedure? So basically, we use all of our material that is coming from the diagnostic archive. So this is formalin fixed paraffin embedded material. And so you can imagine that there is a certain degree of, let's say, lack of quality that comes from just having such fixed material that we can't really do too much about. But we have had some good success with, targeted RNA-seq, not so much with whole exome sequencing, as you can imagine. But it also depends, again, on the not only quality of the tissue, but the quantity. And so if you get cores from tissues that are thick, so when they go into the machine, that they're actually already quite, thick sections or thick blocks full of tissue, then of course your success rate is much higher than if you were to have very thin material going in, or if you're just punching in regions that don't make too much sense, like if you're punching in areas of fat where you don't have a lot of dense tissue or tumor cells, if that's what you're looking at. So again, it sort of depends on the quantity and the quality that you can core out from the block. We don't do anything like frozen TMAs. This is not something that we can use in the machine. So we concentrate principally on using formalin fixed material. We do have actually, we do have a bunch of samples in PAXgene that were fixed in PAXgene, but we have yet to make any experiments on that. The third question is, someone is asking about why can 40 antibodies be done in the TMA at the same time? Well, that's where technology is bringing us. So, I mean, we used to, of course, look at one staining at a time, just like you look at a hematoxylin and eosin staining. You might look at one immunohistochemistry staining at a time. We then progressed to doing double stains, which we very, very frequently do. So we're looking at 2 different antibodies at the same time, or like 2 special stains. For instance, like we might look at, pancytokeratin and, for instance, D240 staining or something like that, which gives us an outline of the lymphatic vessels. And so this would count for us as a double staining. We then progressed to triple staining, as I showed you in the presentation. And when we're talking about these 40 different antibodies at a time, or even more or less, so just a huge amount of antibodies, this is really this generation of multiplexing technology that can be done. So you're basically performing, it depends on, of course, the methods that you're using, but you might still be performing an epitope or antigen retrieval, and then actually be looking for those different proteins that are being expressed. In the way when it's doing, in the, for instance, MIB or Hyperion, you're actually destroying the tissue because that tissue piece needs to get lasered out, and essentially it's time of flight, it's mass spectrometry. So you're essentially labeling heavy metals as like the unique barcodes in that sense to particular proteins, and then you can set them through a mass cytometer and split those signals. So you can reach as much as you possibly can without steric hindrance. You need, of course, a lot of specialization in the protocols in order to be able to set up such panels. But these are really, this is where the generation of multiplexing is going. So very exciting times. And the TMAs are, of course, one very smart way to be able to use the resource of multiplexing to highlight particular, answers to certain questions that otherwise we could never do on whole slides. Imagine you have a study of 500 patients. To be making 500 sections and then doing multiplexing on that is going to be really expensive. So TMAs is really an awesome way to do that. And with NGTMA, you get to really, pick out exactly the regions that you want to put in your TMA. So it's really like, very, very smart technology to use together, I would say. So it seems like there are no more questions for me at this time. To any of the attendees who happen to be online who maybe did not come up with a question yet, if you'd like to contact me, just send me an email or find me on LinkedIn. And otherwise, I guess I will, give the word back to Nicolette, and thank you very much for being here.
Thank you for all of our guest speakers, colleagues, and participants in today's special event. We got a review on the latest development and best practices from these detailed presentations. If you missed something, do not worry, because you can rewatch the whole event here. On behalf of the 3D Histech, thank you for joining us today. We hope you found this information and dialogue valuable, and these 5 hours were worth for you. Have a wonderful rest of your day. Goodbye.